Hello everyone. So today let's start with a case presentation. A 5 weeks old male, first by birth order, born at full term to a 19-year-old mother, was brought to the ER with the complaints of vomiting after each feeding. On further inquiry, you find out that the vomitus was projectile and non-bilious. On examination, the vital parameters were stable. Vitals were stable, but there were some signs of dehydration present in the infant. And on abdominal examination, you find out that there was an olive-shaped mass palpable on the upper abdomen. So with this clinical presentation, what strikes your mind? What is the provisional diagnosis? So yes, you are correct. It is the typical presentation of infantile hypertrophic pyloric stenosis. With this clinical presentation alone, you can make the provisional diagnosis of IHPS. But you need to keep other differential diagnoses like acute gastroenteritis, GERD in mind, because in the initial stage of IHPS, the child presents with occasional vomiting, which later converts into the full-blown projectile vomiting. Other differentials you should keep in mind are metabolic disorders and even intestinal atrasias, because there's difference in the presentation, because in intestinal atrasia the child presents immediately after birth, and the vomiting is bilious in nature, but it needs to be kept in your differentials. So the topic of today's discussion is infantile hypertrophic pyloric stenosis. Hypertrophic pyloric stenosis is one of the most common surgical conditions found in a newborn or an infant. So it is a functional gastric outlet obstruction which is caused by the progressive hypertrophy of the pyloric musculature, specifically talking the circular layer of the pylorus. There are certain risk factors that are associated with the development of the hypertrophic pyloric stenosis, among which there are the genetic factors as well as the environmental factors. Genetic factors, one of the strongest association is if there is a positive family history of hypertrophic pyloric stenosis. It is also more common in the firstborn male infant, and it is also associated with the younger maternal age. Similarly, talking about racial factor, it is more common in the white population than the non-whites. And talking about the environmental factor, IHPS is associated with the macrolide exposure in the infant or the mother, specifically erythromycin. Also, it is increased in risk with the exposure to organophosphate pesticides. HPS, hypertrophic pyloric stenosis, is its incidence ranges from 1 to 4 per 1,000 live births, and the sex ratio is 4:1. That is, there is male predominance. Also, the age of onset is 2 to 8 weeks. It is more common in the full-term neonate. And in the preterm, the development of IHPS takes longer time than in the full-term infants. Talking about the molecular mechanism, so there are certain molecular mechanisms proposed for the development of the IHPS. So some of them include excess of substance P, which can lead to smooth muscle hypertrophy, deficient nitric oxide synthase, because nitric oxide is required for the relaxation, and deficient nitric oxide synthase leads to the failure of the pyloric relaxation. Similarly, decrease in the neurotropins and the gastrin hypersecretion can also lead to the hypertrophic pyloric stenosis. Now let's talk about the clinical presentation of IHPS. So IHPS is usually seen in the full-term neonate, usually between 2 weeks to 8 weeks of age. Initially, it presents with the infrequent vomiting, which can resemble the features of GERD or acute gastroenteritis, but progressively they present with the typical projectile vomiting after every feed. And the vomitus is non-bilious, which differentiates it from the duodenal atrasia or the ileal atrasia. The IHPS babies are infamously known as the hungry vomiter because they vigorously feed again after vomiting. On examination, we talked about the olive-shaped mass palpation. So sometimes it is not readily palpable. So how do we palpate this olive-shaped mass? So first we need to flex the knees of the neonate, and we need to keep the neonate relaxed. We need to keep the infant relaxed, and we can relax the infant by giving them pacifier. We can decompress the stomach by inserting orogastric tube 10 to 12 French. We need to slide the finger under the liver edge in the midline and then pull back slowly. And when we pull back slowly, then the olive-shaped mass rolls under the fingertips. So in this way, we can palpate the olive-shaped mass in about 70 to 90% of the patient when the patient is relaxed. Now talking about the most important part of IHPS, that is the metabolic derangement. IHPS is a surgical condition, but we need to be clear that it is not a surgical emergency, but it is a medical emergency, because the surgical correction can wait, but the resuscitation for the metabolic derangement cannot wait. So correction of metabolic derangement is considered an emergency in IHPS. So there's a typical metabolic derangement present in the IHPS, which is known as the hypochloremic hypokalemic metabolic alkalosis with paradoxical aciduria. So this is a typical metabolic derangement. So in this so there can also be profound dehydration, but nowadays, because of the early diagnosis of IHPS, profound dehydration is very uncommonly encountered. Now let's talk about how this metabolic derangement occurs. First, since there is recurrent vomiting, that is in vomiting there is loss of the hydrogen chloride ions from the stomach. So when there is loss of the hydrogen chloride, then that leads to hypochloremia and metabolic alkalosis. Now, in order to correct this metabolic alkalosis, we know that there occurs a renal compensation. Occurs. So what is this renal compensation? So renal compensation occurs in the form of elimination of the sodium bicarbonate in the urine to maintain the acid-base balance. So when the bicarbonate is lost, sodium is also lost along with it. So there is decrease in the sodium. As we all know, when the sodium is decreased, then there is activation of the RAS. So due to the activation of the RAS, there is aldosterone acts on the collecting duct in order to resorb there is reabsorption of the sodium. And due to the reabsorption of the sodium, there is the excretion of the hydrogen ion as well as the potassium ion. Initially potassium ion, then hydrogen ion. So this leads to hypokalemia initially, and later paradoxical aciduria. So this is how the metabolic derangement occurs in case of IHPS. So first we need to give a bolus of 10 ml per kg of the sodium chloride NaCl normal saline, and then as a maintenance fluid we need to give half normal saline plus 5% dextrose. This is given as a maintenance fluid, and we need to add KCl when the RFT renal function test is normal and when the urine output is adequate. So this is how we resuscitate the children in case of IHPS. Now, talking about the diagnosis. So it is a clinical diagnosis, but the investigation of choice is ultrasound. So in ultrasound, we look for two basic parameters. That is the thickness, pyloric wall thickness, and the pylorus channel length. So the wall thickness, it is seen in the transverse view, and the channel length, it is seen in the longitudinal view. The muscle thickness more than 4 mm is considered in a transverse view, is considered as diagnostic, and the wall and the pylorus channel length of more than 16 mm is considered diagnostic. But in neonates, more than 3 mm pylorus wall thickness is considered as positive. So this is the ultrasound diagnostic criteria. But if the ultrasound is equivocal, it is very undiagnostic, then we can go for the upper GI contrast study. But before going towards the contrast study, we need to confirm, we can confirm it from an experienced radiologist. In the GI contrast study, upper GI contrast study, we can see a string sign. So string sign means there is a narrowing of the pylorus, narrowing in the pylorus due to the hypertrophy, and it is a sign diagnostic of the hypertrophic pyloric stenosis. Now, after proper resuscitation, the surgical management of pyloric stenosis is Ramstead pyloromyotomy. So pyloromyotomy can be done by two approaches, that is the open approach and the laparoscopic approach. So nowadays laparoscopic approach is considered the standard of care. In the open approach, we give an incision in the right upper quadrant. We give a transverse incision in the right upper quadrant. Then we exteriorize the pylorus, and then pyloromyotomy is done. And then at last we check the mucosa. And if there is any tear in the mucosa, then we correct it immediately. Similarly, in laparoscopic approach, we obtain access, we insert the ports, we incise the pylorus muscle with the spatula tip cautery, and we use pyloric spreader to open the muscle. At last, we visualize the submucosal bulge, and air is instilled in order to confirm if there is any leakage. So in this picture, we can see that this is the hypertrophic segment of the pylorus, hypertrophic pylorus, and here a longitudinal incision is given through the serosa, and the hypertrophied muscle is split until we see the herniation of the mucosa through the incision. So this is the intraoperative image of hypertrophic pyloric stenosis. Similarly, in discharge, in the post-operative care, we need to now the new guidelines suggest that early feeding as per the demand is recommended. And even if there is there are some episodes of vomiting, still we continue the feeding. And as soon as the infant tolerates full feeding, we can discharge, which usually happens on the post-operative day 1 or 2. For analgesia, we prefer paracetamol or acetaminophen. Okay, so now let's talk about the complications and outcome of hypertrophic pyloric stenosis. In the historic times, the mortality from pyloric stenosis used to be around 50%, but now the mortality risk is less than 0.1%, that is nearly zero, with appropriate preoperative resuscitation. So we need to always correct the metabolic alkalosis before operating. Other complications include the risk of mucosal perforation, which is around 1%, and when the mucosal perforation is encountered, we need to close it immediately with the absorbable suture, or we can also put an omental patch over it. Similarly, there may be risk of incomplete myotomy. So the incomplete myotomy can lead to persistent obstruction and prolonged post-operative emesis. So in such cases, we need to repeat the pyloromyotomy again. Similarly, there is risk of wound infection, which is more common in the open approach. Also, incisional hernia, it is also more common in the open approach. But overall, the complication rates are around 1 to 2%, and there is very not much significant differences in the open and the laparoscopic approach, although the laparoscopic approach is more cosmetically appealing. So this was about pyloric, infantile hypertrophic pyloric stenosis. I hope you all learned something, and I will see you in the next one.